Good morning everyone. My name is Sean. I'm from the United States. It's a great honor to be able to speak here today. Today I'd like to talk about the case of rupture of popliteal artery aneurysm. First, I'll give you a brief introduction on popliteal artery aneurysm. Then I'm going to present a case. Let me start with a popliteal artery aneurysm. Actually, it's the most common aneurysm in the peripheral artery. Thrombosis and distal embolization are the most common complications. Many centers use diameters, so 2 centimeters, as an indication for operation. So, does it rupture? The answer is yes. However, the rupture is unusual. The patients usually come to you with leg pain and swelling. Once they rupture, they can lead to compartment syndrome and limb amputation, and even to death. Most of published previous cases had open surgery with fasciotomy and amputation. Alright, so let's move on to our case. The patient is an 86-year-old woman with a past medical history of stroke and hypertension who presented with a severe pain in the right leg. CT scan was taken and a ruptured popliteal artery aneurysm was found, and she was transferred to our hospital. At the ER, the patient was in shock and groaning from the pain, with a blood pressure of 86/40. Heart rate was 120 bpm. Her right leg was massively swollen and tense. We couldn't palpate the peripheral arteries at all. This is a CT scan finding. Here's an enlarged image of popliteal area. At the level B, you can see the aneurysm at the level of distal part of popliteal artery. There is a hematoma in picture D, which is just below the aneurysm. Considering her situation, we performed urgent endovascular treatment. A several sheath was inserted into a right femoral artery. If you look at DSA image on the right side, you can find popliteal artery aneurysm with a hematoma, same as the CT result. There's an ATA flow running down this way. You can see here, right? So we first tried to advance guide wire by antegrade approach. However, we couldn't make it. So we approached from retrograde through a distal ATA. We snared the retrograde wire and succeeded in rendezvous. Now this is IVAS finding. I'm going from the bottom. At the level E, distal ATA is intact, and at level C and D, IVAS is still in the ATA, but is compressed, totally compressed by hematoma located here. At the level B, you can see the entry site into the aneurysm. Here are the points of our case. So there was a ruptured popliteal artery aneurysm here, but we could identify the entry site into the aneurysm. Although distal ATA was intact, entry site of ATA was compressed by hematoma. And most importantly, she was in shock. So what would you do? First, we performed a coil embolization to reduce pressure inside the aneurysm and prevent further expansion. So we first put 4 coils into the aneurysm. Then 5 by 50 millimeters stent graft was deployed to exclude the aneurysm, and self-expand nitinol stent, which is CPET, was placed from the proximal ATA to inside the stent graft to keep it open. So let's go to the bottom. And after the operation, the patient had an uneventful post-operative course, and she was transferred to another hospital for further rehabilitation.